We mostly look at ankle ligament injuries and how they affect the joints. I've got a little bit of theory for you first of all, and then we will go through a little bit of therapy and therapy ideas of things that you can perhaps use to both assess yourself or your student, but also to then provide a little bit of therapy for them. A little bit of background now, 20%, can you believe, 20% of all emergency department visits each year in the USA are ankle sprains. It's an incredibly common issue that you will come across again and again. Incredibly high number. 85% of those are lateral ankle sprains. So lateral, if you're not familiar with that term, is on the outside. So this is the ankle joint. This is the tibia. This is your lower leg bone, the largest one in your lower leg. And then you've got this thinner bone on the outside of your leg called the fibula. This is the lateral side, the outer side, and this is the medial side, the inner side. So 85% of these ankle sprains are lateral. They affect this side of the joint. And when I say joint, that's a little bit of a misnomer really, because it's made up of multiple joints. It's really a joint complex, as many joints are. There's numerous joints through here that can be affected. With a lateral ankle sprain, the most common joint that's affected is this one that we can see through here, the largest joint of the ankle, called the talocrural joint. It's made up of the tibia and this bone through here, which we can just see a little bit of, called the talus. Now, distortion of joints and ligament rupture can lead to a disturbance in proprioception instability. Now, what does that mean? Proprioception is essentially our awareness and control of movement, our ability to send our finger out in a direction and keep bringing it back to our nose, without even looking. I can do this again and again and again because my brain understands where my joints are positioned, and then therefore can make very precise contractions to carry out that movement and stop me poking myself in my eye and actually touch my nose. When we have an ankle sprain, essentially a damage or an injury to the ligament, whether that's a tear or full rupture. So a tear, normally the ligament is connecting like this. Maybe now there's a tear and it's not fully connected, or a complete rupture where the two ends are completely separated. Those nerve endings, which supply information about the position of the joint, is lost or disturbed at the very least. And it means that our brain's ability to understand exactly what's going on with the joint is also diminished. And it means that now the joint is very vulnerable to further injury. It means that every time the individual might take a step, that they don't feel quite sure of their footing. Their balance may be compromised because their brain is trying to figure out what's going on, but it's not getting quality information. And this is one of the biggest things that we have to try and overcome, both in the short term and the long term. 40% of these lateral ankle injuries that we're seeing turn into chronic instability. So longer than, depending on which definition you go by, but more than 2 or 3 months. So the problem is continuous, it's going on for months rather than just settling down after a period of 6 to 8 weeks. And 5 to 33% of patients still experience pain and subjective instability after 1 year. Within 3 years, 34% of patients report at least one sprain. So this is super, super common. An individual injures their ankle, and then sometime later they injure it again. And this can become just a chronic thing that goes on, and they are not able to overcome it. Let's just take a very quick look at the ligaments around the ankle. We look at the inner side and the outer side. This is the inner side. This is the outer side. As I said, this is the fibula, the smaller bone on the outside. That's called the calcaneus. This is your heel bone through there. And then we've got this bone called the talus, which runs through all there and underneath. On the outer side, there's a few ligaments which really help to stabilize this side of the joint. And on the inner side, we've got a group of 4 ligaments, which we collectively call the deltoid ligament, which stabilizes the inner side. Now, when we go into, let's see if this video will play. When we go into an inversion injury, where the ankle rolls in like this, we're obviously going to stretch these ligaments on the outside, and that can lead to their rupture. Let's just play the video. This is the joint just going into, that's dorsiflexion. So the foot, there's my leg here, my toes are up here. That's me going into dorsiflexion, and that's plantar flexion. So extension and flexion. At the moment, we've got extension, and that's plantar flexion. That's how the joint should move. These surfaces should stay nice and aligned and in a fairly tight position. What happens when we go in an inversion injury? Something like that can happen. And you can see the distance between my thumb and that bone increases. And that will greatly stretch the ligaments through here, particularly this ATFL, the anterior talofibular ligament, and can lead to its rupture or a tear. That's the type of mechanism which is taking place. It can affect other joints. I've simplified this a little bit because it can affect underneath through here as well. But essentially, that's what can happen. Let me just play that through for you. You can see really the joint opens up. That joint should not move that way. When we go on the opposite side, and this is much rarer because the joint is more stable in this direction, this type of movement would cause a medial ligament injury, so to the deltoid ligament, and usually via an eversion injury, but quite often as well via increased dorsiflexion. So the joint is greatly extended, and then the joint rotates. There's an external rotation. Usually, most commonly, it's seen, for example, perhaps in a soccer player, they plant their foot and then lean forward and then try and turn. As they turn, they create twisting at the ankle and injure this ligament. But as I said, 85% on the outside, and that's what we're going to focus on today in terms of understanding that a little bit better and how we might be able to manage it. As I said, the ATFL is the most commonly torn. Now, the complications are numerous around this particular type of injury. What we can find is when we move the joint in this kind of negative way, let's just play this back for you. You can appreciate this is normal motion. And when I go into this type of movement, the bone surfaces can apply unusual pressure to the joint. So the bones actually impact into each other in a detrimental way, and that can lead to cartilage damage. The most common way that an individual will end up with ankle osteoarthritis, which is not the most common joint to have osteoarthritis, the hip and knee are more likely to experience it. But when the ankle is injured, when there is trauma, the risk of cartilage damage is very, very high indeed. And this can be one of the contributing factors to why the individual has ongoing problems, not just the ligament issues we've talked about and the instability, but actually because the joint has an injury to it. Yeah, the joint surfaces. This is a CT scan of a left ankle. There's the tibia, there's the fibula, and this is the talus. This part through here is called the talar dome. And this talar dome is articulating primarily with the tibia. Can you see this little part through here? This is actually a fracture. This is where the bones has moved in at a normal way. So this kind of movement, or perhaps this kind of movement, and some kind of force has actually caused the bone fracture. And that is a problem because now we've got this kind of piece of bone in the joint. The cartilage has been affected, and every time the individual moves the joint, so like this, backwards and forwards, this little piece of bone is getting in the way, and that movement therefore becomes irritating all the time. This is quite a marked change that we see. Sometimes it's much more subtle. On a CT scan, we're seeing mostly the bone as white and gray. This is being represented by the dark area as cartilage. So when we're talking about cartilage damage through here, it's actually taking place to this kind of softer tissue, which helps to enable the joint to move more efficiently without friction, acts as a shock absorber, and helps your joint to last most of your lifetime. When there's an ankle injury, as we're discussing, this cartilage can be damaged. In an extreme case, we can actually get a fracture as well. Cartilage, I describe as extremely lazy tissue. It's very, very lazy. It doesn't do much work. And so often what we find is that when there's an injury, the tissue's ability of the cells, the chondrocytes they're called, their ability to actually repair the tissue is very, very limited. When you add into that the insult that we're providing to the joint on a daily basis, so each day we move our joints and we create a little bit of micro trauma, again, it means that the cells just don't have the capability to repair. And that's why we generally see that all our joints are degenerating slowly. We want to minimize that degeneration so it never really bothers us, because time they are degenerated, we're not alive any longer. If the degeneration is happening too quickly, then this leads to osteoarthritis. It leads to perhaps someone wanting to get a knee replacement or a hip replacement, this kind of thing. So we need to try and appreciate that this cartilage is quite a sensitive tissue, and we are in a position where it doesn't have a very good ability to repair itself. In any situation, even if there is cartilage damage, what can we do to try and minimize future irritation? Can we get the joint to work more efficiently? Can we ensure that the movements are really pure and clean, and therefore minimal stress to the joint? Because if the stress is too much, we create more damage. If we minimize it, minimize the stress, we minimize damage, and therefore we have the opportunity of the joint lasting much, much longer. So when we come to thinking about rehabilitation, that's our primary concern. How do we get the joint to work better and more efficiently? 89% of lateral ankle sprains, so the sprains with inversion injury, so the joint has gone, as I talked about, that way, 89% of them will have an injury to the cartilage. Not as severe as this, but there'll be some minor damage. In the short term, that will be quite uncomfortable. And in the long term, as I said, it can lead to osteoarthritis. At that point there, the recurrent ankle injury, so an individual who sprains their ankle once and then keeps doing it, recurrent, is the second leading cause of ankle post-traumatic osteoarthritis. Around the joint, after this type of situation, there'll be muscle weakness. So the muscle supporting the joint, they won't work as efficiently. There's a few different situations. The nervous system actually adapts in a way to, in some ways, protect the joint and preserve the joint, but in other ways, it doesn't do a very good job at it because the muscles lose their ability to create a lot of force and generate power. And therefore, with that loss of strength and power, and also endurance to some extent, the joint is less stable. So the individual is more likely, again, to injure themselves. There's also these altered biomechanics. As I mentioned, the joint won't move as cleanly, as purely as it should. There'll be accessory movement. So, example, if you see my hands here, just on my pop-up, if the joint is supposed to move like this, and this is a very simplified version, and that's normal, we get these accessory movements, okay? These different types of movements in the joint, and that creates more stress, more friction, and breakdown of articular cartilage. There'll be abnormal patterns of pronation and supination. And it means because we've got these altered biomechanics, every time the individual walks, every time they do maybe a squatting movement or a lunging movement, or step from samasthiti to a standing posture, the movement isn't quite correct. The ankle doesn't move quite correctly. And because it doesn't move correctly, it irritates the joint again and again. And again, that leads to that breakdown. So this is why it's so important to rehabilitate these issues to try and minimize future stress. I touched upon this earlier. When there's chronic instability, so the joint is too loose, there will also be muscle weakness. And I think many people already appreciate that when there is a joint issue, we generally want to strengthen the muscles to try and stabilize the joint. Strengthening the muscles is one thing, but perhaps the most important thing for me and many other therapists is trying to improve the control and the awareness. You've got to build the connection from the brain to the ankle again, because as I mentioned, there will be changes to the ligaments and therefore the nerve endings within them signaling up through the leg to the brain, and the brain then communicating to the muscles to control the joint and make sure it's in a good, healthy position. So strengthening is good, but mindful strengthening using slow movements with complete awareness is by far the best way to go. And this is why yoga is so fantastic, because generally we perform movements mindfully, slowly to begin with, especially. And we build up that communication between our mind and our body, which is very, very important. If you go to a gym where there's music blasting away, people jumping around all over the place, then there's less ability to be aware of your joints. And therefore that awareness is just not built upon. It's so, so important. The 4 risk factors involved in primary or recurrent injury, so an injury taking place for the first time or happening again and again, are strength, proprioception, range of motion, and balance. So let's just break that down. If the individual is strong, they can make movements, they can come up onto their toes, for example, raising their heels, and their muscles have enough power to do that. Their ankle is going to be protected. If they haven't got the strength, for example, to raise it up onto their toes, lifting the heels up, then they're more likely to injure themselves. If they don't understand, when we come to proprioception, where the foot is in space, again, they're more likely to injure themselves. Remember, I said that proprioception is our ability to bring, for example, my finger to my nose repeatedly. I should be able to, blindfolded, put my foot in a certain position and know exactly where it is. If I don't, if it's off slightly, then it can lead to a lack of control of the foot and therefore increased risk of injury. It reminds me a little bit of in cervical rehabilitation, when we have, for example, a whiplash injury, when there's an injury to the neck. One method that they can use sometimes is they essentially put a headband around your head with a laser, and then you move your head in different positions, and then you have to precisely point the laser to a board in front of you. And they're fine, for example, in someone with a really healthy neck, they can bring that laser back again and again to the exact point. Someone after a whiplash injury, so after a car accident where the head is being sent forwards and backwards, and there's a huge strain to the ligaments and other tissues of the neck, their ability to bring the marker, the laser, back to the right point is very varied. Okay, it'd be very, very mixed. Think about that in the foot. We should be able to reposition the foot and know exactly where it is every single time. If we don't, then we don't have control. We have a greater risk of issues. Range of motion. So we want to make sure that the ankle can move in all the different directions. So plantar flex and dorsiflex and invert and evert and abduct and adduct, these different ways. And we want to make sure that they can do that in a balanced way. In some instances, you may find an ankle moves too much, is moving too much in a certain direction. And in other cases, you may find it can't move enough in a certain direction. The benefit when we've got, or we're working with an individual, is they've got 2 feet, and 2 ankles, we can often compare sides. Ideally, if they've not had an injury on this side, for example, but they have on this side, we compare what they can do on the healthy functioning side and see what they're doing on the negative side, or the symptomatic side, I should say. If, for example, I see restricted movement on this side compared to this side, I know I'm probably going to need to improve mobility in that direction, as long as it's not increasing their pain. If I see increased mobility on this side compared to the healthy side, I know I don't want to do too much of that movement. So for example, if I see, these are my 2 feet, there's my big toes in front. If, for example, I've got a lot of inversion on one side, so I can turn the sole of the foot on the symptomatic side more than the other, I do not want to encourage that movement more. In fact, I want to work in the opposite direction. I'll actually want to work on eversion more and limit inversion. And you can apply that to any joint of the body. Yeah, it's quite a simple way to think about working with someone with a joint problem. And just so regarding around balance, a balance, for example, when we stand on one foot, standing on one foot, raising the foot off and just trying to hold that position. When this is compromised, obviously you're less stable, you're more likely to fall over. Your therapy should try and think about those different points. Yeah, consider that because then you've got the best ability to actually be able to help someone. Now, it says here that exercise therapy should be used and treatment should commence within 12 months of injury. So there's certainly the argument that the sooner you start it, the better. But there also seems to be an argument that if you start it within 12 months, you've got a better chance of working or improving the situation than if you wait longer than that. That doesn't mean to say that anyone after maybe they had the injury 2 years ago or 18 months ago, doesn't mean that you won't get an improvement. Certainly you can work with chronic ankle injuries that have been there for years and years and get lots of improvement just by doing some simple things that we're discussing today. I touched upon this a moment ago, and that's the action of the everter muscles and needed to counteract inversion. So inversion is turning the sole of the foot in, and eversion is turning the sole of the foot out. Now, because most ankle injuries, let's just go back to here for that image. Because most ankle injuries are inversion, rolling over. This is an inversion movement. We actually want to make the opposite movement where we take the sole of the foot the opposite direction. That can be an important movement to work on. Because if you're stronger in the muscles which make that movement, you're less likely to go that way. Does that make sense? Because it's been seen that essentially there's a delayed response by these muscles after inversion injury. Okay, and that can be involved with chronic ankle instability. So this inversion movement, again, is really, really important to think about. And interestingly, ultrasound, laser, electrotherapy have no added value and are not recommended, nor is surgery for most of these chronic ankle instability cases. Certainly there will be exceptions to the rule here and there. Certainly for high-level athletes and sports people, often they perform surgery on ankle ligament injuries. But for the average person, it's usually not needed. Essentially, the therapeutic movement that you can use or utilize, for example, with doing yoga, is usually sufficient. Let's just look at a few movements. And I encourage you to do these with me so you can experience them a little bit. My head is going to be cut out. One of the first things that you can look at is their ability to balance. So very simply, starting with the feet together, just trying to raise the foot off the ground and see how well they can control that. Now, someone with an ankle injury, you might see different things. You might see a lot of movement, and it typically will happen a lot around the ankle. It'll be rolling in, the foot will be flattening and moving outside. The toes will be grabbing a lot, especially the lesser toes. They're really trying to grip into the ground quite often. A lot of movement. With a more chronic and with a more severe injury, even an acute injury as well, then their ability to balance will be very compromised. They might not be able to do it at all. Compare one side to the opposite side. Generally, if I'm working with someone with an issue, for example, on the right side, I get them to do it on the left side, first of all, just so they fully understand what they're trying to do, get a baseline of what is good for them, and then compare it to the compromised side. In an elderly individual, someone with really compromised balance, then obviously you want to give a bit of support. But for example, if you feel that you have to give the individual support just to be here, there's no point actually doing that movement. Yeah, don't worry about it. But essentially now, as you stand here, let's do that together. So try and come up onto one foot. Make sure the toes are relaxed. Try and keep your trunk nice and straight and aligned. And you may feel a little bit of twitching in your foot as your body adjusts, and that can be fairly normal, but it shouldn't be any major, wiggles or deviations of the trunk. And ideally, you want that individual to be able to hold that for at least 30 seconds, and then you can compare the other side. And get a baseline or a better understanding of what's taking place there. And again, really feel the foot, how the foot is working. Make sure the toes aren't grabbing. Appreciate how the weight may move around a little bit on your foot as you balance there. So ideally about 30 seconds. Now, in someone who's very active, perhaps they're a sports person, and they may have a chronic ankle issue, they may in that situation look pretty normal on both sides, even though they may say this I'm having a lot of issues on this side. Balance the eyes open can be quite normal. Try with eyes closed. It will just increase the challenge and ask their joint to give more information rather than using their eyes. So with the eyes closed, try that for me now. Try and stand on one side, eyes closed. And again, you're looking for about 30 seconds. Again, making sure nothing is contracting too much in the foot. The body is nice and straight. You're looking for any deviation. And then try on the opposite side. Again, close the eyes, raise the leg. Now, just one thing around that movement, you may have already noticed there's a bit of difference between sides. You may feel perfectly balanced, which is great. One thing to say around that, if the individual raises the leg and they go straight away, don't keep trying to do it. They've already failed the test because you need that perfectly straight. There's no benefit of holding this position for 30 seconds. Any major deviation, just come down and start again. And time it. With practice, that individual will often get better and better. They just practice that particular movement. Starts with the eyes open. If they really need to, they can take a little bit of support from the wall. That's one thing to look at. The other thing to look at is a heel raise. Okay, so you can break this down into different ways. Now, ideally, the foot is perfectly aligned to begin with. So if you can see my foot from here, I've got fairly decent arches. We don't want that to really collapse in. And it may, from the back, it may look something like that, where the ankle kind of rolls in and deviates. So ideally, you've got the individual, they've kind of aligned themselves well to begin with. They've got a good foundation. And you want to look at their ability to come up on their toes, control that movement, momentarily pause, and then come down. Now, you may find there's a few things you can find when you do that. One is as you come up, you can't control it, you kind of fall back down. The other is, and this is the typical issue that you'll see, particularly with a lateral ankle injury, when they come up, I'm going to mimic this a little bit on one foot, they'll roll out. That part of the ankle will start to buckle outwards too much. It will just a tiny bit because it's the natural movement of the joint. But too much, that kind of direction, it rolls out, is something you want to completely avoid. So essentially you want to see those heels going straight up, pretty much, and straight down. If the individual can't do that cleanly, if they are moving off in different directions, then what you want to do is, to begin with, you take a little bit of support, maybe with the chair, or you use the wall, and instead of coming up way high, you come up just to the point where they can control it with good alignment, and then they come back down. They come up just a tiny bit, and then they come down. They do that a number of times. If after maybe 5 or 6 times they start losing control, stop. Every time alignment is lost, every time control is lost, stop. And either that's enough for that particular moment, or you need to make it easier. Because there's no point being up here with poor control. It's not going to protect the joint, and you're going to stress the joint adversely. Once you've got to a point where they're doing that cleanly, using support and lifting the heels up completely, take away the support. And again, now you've got no support, and you might just lift up just a little bit and back down over a period of weeks. You increase the height. You want to get to a point ideally where, and this is again where you need to take into account what the individual needs and requires, their age, their hobbies, all these different things. A younger individual who wants to perhaps play sports, you want to get them to this point where they can stand on the one foot and balance, and then raise, sorry, difficult to do when you're talking, we're doing that, so to come up and down, okay, 5 times. So come all the way up, control it, back down. So with perfect control and alignment. Mine isn't perfect because I'm trying to talk as I'm trying to do it, which makes it a little bit trickier. But that's the ultimate goal. Well, not the ultimate goal, but a very good benchmark of when you know someone has good control over their ankle. If they can't do that 5 times cleanly, then you need to get them stronger. Once they get to that point where they can come up, then often they can start thinking about returning back to sports and be fairly safe. There's other more refined things that you can do as well. For an older person in their 60s, 70s, not very active, do they need to do 5 heel raises with complete control? No, they can still function very well and have very low risk of falling. But as you can appreciate, as we get older, our balance ability reduces, our control over the body decreases. And one of the greatest risks that we have in later life is falling over and, for example, fracturing bones and damaging joints. So the better control we have of balance, the better we are at it, is a great thing to move towards for yourselves, but also for your students, to keep working that, keep developing that. So that's a few ideas. There's lots more that you could think about, but that might give you a few ideas in terms of how you might start looking at some ankle problems.